is our first video.
Exciting stuff.
Yeah, so I think we so this video is a follow-up from the podcast episode we did on proton therapy. I think the intention, we can kind of tell people that the intention was to include reviewing, Julie, your proton plan in that. And the main goal there is that I think your specific case is a really nice case to illustrate kind of the nuance of why a patient and their doctor may choose proton therapy over X-ray or photon therapy for their radiation course. And so we wanted to use that kind of as an example. And you were kind enough to kind of donate your plan so we could look at it on the computer and go through it. And we tried to do that audio only, but it didn't work so well. So we're going to do our first video to kind of show this time. Anything to say before we start? I have a few slides to give some background so that we can kind of give some more context for how a radiation doctor may pick proton therapy over X-rays, and then also for how we might review a radiotherapy plan and kind of what things we look at.
I think we're ready.
I'm good. I'm excited to learn something about my case that maybe I didn't learn the first time.
Okay, so I have these slides. I won't make it like too much of a lecture, but I just wanted to go through a few things so people can understand how we approach this case together when I saw you in our clinic. So I know that we've talked a little bit about your case on other episodes, but for the pertinent points here, just so people are aware, what we're talking about is a case of an undifferentiated pleomorphic sarcoma. And that's just a type of sarcoma. And then importantly for this, it was high grade, which drives a lot of the recommendation for radiation. And Julia, correct me if I'm wrong, but my understanding from reviewing the details, this was kind of a little while ago now, but this was found on a mammogram. It was biopsied and it was inconclusive. I think we talked about that some on one of our earlier episodes. And then you had a lumpectomy, and that's where we got more definitive pathology that showed, again, a specific type of sarcoma called undifferentiated pleomorphic sarcoma. And then I always tell our trainees the two most important things you pull out of the path report for a radiation doctor deciding to give radiation before or after surgery for sarcoma would be that it was high grade or grade 3, and then it had unclear margins at the time of that lumpectomy.
Correct.
Yeah, and then you appropriately went on to get what's called a mastectomy. So just so patients know, the lumpectomy takes the tumor right out of the breast or the chest wall, but kind of leaves the rest of the breast behind. But with sarcoma, you want to try to get wide margins, and we can talk about that maybe in another show, but you want to try to get as much normal tissue that you can take safely so that you minimize the chance of it coming back, because sarcomas tend to kind of try to spread locally and have cells remain behind after surgery. So a mastectomy takes off the breast tissue and leaves behind the chest wall structures. And by that, we mean like the ribs, the pec muscles, nerves, and things like that. But the breast tissue comes off totally. And then after you had that then had negative margins. So the idea is that the sarcoma was gone entirely. When you look all around the edges of it, there's no tumor cells that we can see left behind. Anything to add from that? I think that was there were more details, but I think those are the radiation relevant ones.
Yeah, no, that was all correct. I guess I did have a question on, you mentioned that one of the things that you tell radiation oncologists to look for is, high grade and margin status. And you mentioned that though specific to sarcoma.
Yeah, no, so that's a really
for
good
other cancers, just because we have people with other disease types who listen.
Yeah, no, that's a really good point. So I should say grade, the grade of the tumor and the margin status are important in maybe almost all or all cancers. There's probably examples where maybe is less important, but you would actually look at those for all different types of cancer. And much more common question for radiation oncologists to think about compared to a sarcoma of the chest wall would be a breast cancer of the breast, like a kind of what we call invasive ductal or invasive lobular carcinoma. Those are much, much more common, but the same principles are here, where the grade tells you sort of it's like a surrogate for the aggressiveness of the cancer. And again, just to be clear, there's a lot to talk about with grade, but for the purposes of this discussion, that just means that it's likely to act more aggressive than a grade 1 or a grade 2 sarcoma. And then also the margin status talks about if they find any cells along the edges of where the resection was done. If there are cells along the edges, that would imply or suggest that there could be a higher chance of it coming back. And you do, you look at those features with other types of cancer as well. Yeah.
So just one more question about that is that the lumpectomy did have unclear margins, but the mastectomy had clear margins. And so by the time I came to see you, the pathology would have referenced, clear margins from the mastectomy. So how does the unclear margin status play in?
Yeah.
Given that those margins were clear, if that from the second procedure.
Yeah, and it really matters what kind of cancer you're dealing with, right?
Okay.
So you would handle a margin differently, a positive or a negative or indeterminate or unclear margin. You would handle those all differently based on the different kinds of cancer. So just to give a quick example that's more common and probably more common for most listeners is that if you had a breast cancer, like an invasive ductal carcinoma, and then you had a lumpectomy, meaning that there was still some breast tissue left behind that could be taken out if there were unclear or positive margins. Usually you would just go back and do another surgery to try to clear the margins and get them to be negative. You take more tissue to try to get those cells out. In this case, with the mastectomy, there's not really more tissue that can be taken in some cases. And so where the margin status might affect you for sarcoma is it would actually give you a sense of what dose you need to give. So in your case specifically, say they did the mastectomy and they said, there's a small positive margin along the pec muscle, and the only way we can make that negative is to take out the entire pec muscle. That would have a lot of side effects and a lot of morbidity. Most teams would then agree together where the surgeon and the radiation doctor would say, okay, I know that it would be too much morbidity to take out that positive margin. Instead, what we're going to do is we'll leave it there and we're going to give it more radiation to try to kill any of those cells that are more likely to be left behind in that positive margin situation. And that's something that happens a lot in the sarcoma world. And so with your case, really what we were looking at was, do we need to give the negative margin dose or the positive margin dose after the surgery, which is kind of something that we do in the sarcoma world that's been set by prior clinical trials.
And does that matter based on her mastectomy was a negative margins, but the lumpectomy was positive? It doesn't matter if it's the second one got negative and that's the one you go off of?
Yeah, we would go off the kind of most recent or most complete one. So the idea is those positive margins, they could have been there. And then when they do the mastectomy, they take off all the remaining tissue where that margin would have been. So it becomes negative. And so this is very anatomically defined. And so everyone's case could be a little different. And what I mean by that is how the margin status is reported out, the importance of it, and then what you would do about that really does vary a lot from patient to patient based on the type of the disease, where you're doing the surgery in the body. You can imagine some places it's easier to go back and take more tissue than others. And then also if there's a way to deal with it. And in sarcoma, for example, sometimes leaving a positive margin is the best thing for the patient. And we just have ways that we can increase the radiation dose to try to help with the fact that there could be more cells left behind. Those are great questions. And that's really, this is actually the way that I would approach this. And other than those things, you try to make a decision about whether radiation is indicated or not. And I can tell you that in sarcoma, it is standard of care in most patients that have a surgery, even if the margins are negative, to give post-operative radiation therapy if it's a high-grade tumor. And the reason for that is that we know from clinical trials that for high-grade tumors, if you take them out, even if the margins are negative and you do nothing else, the chances that it comes back in groups of patients is higher than oncologists or doctors are comfortable with. And so that's why it's a standard of care to give the radiation. And just to be complete, you can give the radiation either before or after the surgery, That's something that's been kind of a controversial discussion in the sarcoma world with radiation relative to surgery. More and more we're doing doing radiation before surgery, but there's certain parts of the body where it makes more sense to do it post-operatively. And in Julie's case, the chest wall is one of those examples. Part of why is that we as radiation doctors give radiation all the time to the chest wall after surgery in the breast cancer world. And remember that breast is the most common cancer in women. And so it's a very common thing that we give radiation for. And a lot of the principles we think about were kind of founded in that space. And so we sort of borrow it in the more rare cancer space like sarcoma. And so I don't want to get people get too caught up, but I did want to mention that more and more we're giving radiation prior to surgery in the sarcoma world, even though in this case we do give it after. So the things that I would think about for your case specifically, Julie, or what we always think about, it is a standard of care, but what are the biggest things? And the three questions that I would ask for every patient after surgery, if we feel that radiation would help, is what are the chances that the cancer comes back? If the cancer is unlikely to come back with just the surgery, then you probably don't need additional therapy to help. In this case, though, as we just said, sarcomas come back with a pretty high rate if we just do surgery and nothing else. And so in that case, it would be a high chance of it coming back. The other thing we like to think about, and this is a little bit morbid, so I'm sorry, but for all patients, we want to think about what's the chances that something else happens to them that affects their life or has them pass away before the recurrence. Just to give an extreme, Julie, if you were 105 years old and you came to my clinic and you had heart disease and diabetes and we plugged your numbers into the Social Security life expectancy tables, you would see that your life expectancy at 105 years old is pretty short, right? It takes time for cancers to come back. If I had a crystal ball and I knew that you were going to pass away 6 months after your cancer surgery, it may be that all that radiation may not actually benefit you because you have to be alive to have a recurrence. And again, I'm sorry for the morbid language, but it is an important thing that all doctors think about when they're doing therapies to be added to surgery afterwards. And then what are the chances of benefit? Does the radiation work? We do know for sarcoma that if you give radiation before or after the surgery, that the chance of that tumor coming back where we radiated is really, really low. These days with modern radiation, proton or photon radiation, we're talking less than 10% chance of it coming back. And so we know radiation works well. It's a high chance for a bad outcome if we don't give it. And in this case, Julie, we expected you were a very healthy young patient. So like many patients with sarcoma, we expect them to have long lives ahead of them. And we think there's lots of benefit to be had for adding radiation. So that was a decision about why to give it. How we do it, I don't want to spend too much time on this. We can do a sarcoma dedicated radiation show, but basically for this, what we do is we use, this is a leg. So this is a little bit of a leap here, but same concept where this white area represents the tumor bed or where the tumor used to be. We'll often discuss with the surgeon. So Julie, I had a discussion with your surgeon about where the tumor was and where we think it could come back. And that becomes our target. And then radiation doctors do two things to that target. The first is they add what's called a clinical target volume, which is in this figure. You can see my mouse stopped cooperating, but in this figure, you can see how this white area has a little bit of gray kind of around it. This is an area where we think microscopic cells could be hiding, and it has a specific shape that's just defined by the literature. There's a study here if people wanted to go read about it. This is how we make our targets. That's where we're worried about the cancer could be. We add a little bit more space in this figure. It's 1 centimeter around that gray area. That's called the planning target volume. And this helps us take into account things like if Julie is set up to the left or the right a little bit off than we expect one day or the other, or if the breast tissue swells a little bit or the chest wall tissue swells a little bit and it makes that the target a little bit further away from the skin. Our plans are so precise these days that if we have small changes in patients' anatomy, it could affect the way that the dose falls. And so we build in that wiggle room to make sure that there's no issues when we're delivering the radiation throughout those courses. And so that's how we define the target. And I'll show that in just a second in her plan here. And then we come up with a final recommendation, and that's set by standards of care. And so any patient can ask their radiation doctor where the dose and the prescription comes from. This prescription came from a Canadian trial that set the standard for how we give radiation for sarcoma, for patients that have sarcoma before or after surgery. And so that's what this is. So what was prescribed for her was 50 gray and 25 fractions to that bigger field. And then we usually shrink our field and we do a little bit more, in her case, 5 fractions for 10 more gray to that tumor bed. And that's what comprises the final recommendation of 60 gray and 30 fractions for post-operative treatment of sarcoma with negative margins. That's just a standard thing that we would give to any patient. And I think we've talked about this before. In the future, we may hope to have certain types of sarcoma might require less dose. So maybe we drop the prescription if it's a certain type. We're investigating that for things like, for example, myxoid liposarcoma seems to be pretty sensitive. So these days that can get a little less dose than this one can. But we're a little far behind our medical oncologist colleagues in customizing treatment to the genetics of the tumor or the genetics of the patient. So radiation doctors need to come forward a little bit there. The last thing I'll think about is, this is where we get to the part, how should we best treat the patient? Should we use photons or protons or something else? And this is where we really think about that. And it's what's by where we're treating. Remember from the episodes, we talked about how the side effects of radiation are only related to where we treat. And so knowing the anatomy of the situation means a lot. What are we treating in this case? For Julie, it was the chest wall. That's what was left behind and where the tumor was kind of residing. And we wanted to make sure we sterilize that area. The chest wall is a medical term that we'll use to describe the muscles, the ribs, and the nerves that are kind of in the area of the chest where you can kind of feel it. The lung is underneath the chest wall. So that's definitely something we need to think about. I have that listed twice, actually, so there's an error in real time. The heart is also something we need to think about. And with those two, they're actually a bit different. The heart, for example, is close by, but it's a little less understood. And I'll show this on the next slide, where our understanding of how radiation might stun or injure the heart, and then how the heart heals from that over time, is a little less understood. On the other hand, the lung, we do know from our extensive experience giving radiation in the breast cancer world, in the lung cancer world, that we can actually give a fair bit of radiation to the lung and people can do very well without a lot of side effects, and it heals very well. And so those are two things that are close by that have different ways to consider them. The other things that we would think about is the esophagus. That's the tube that connects the mouth to the stomach when people swallow, but that's pretty far away. And I think any type of radiation, we can do a good job of not giving radiation to that area. And then the last part is the other breast. We know from studies of childhood cancers, we talked about this in the Proton show, that low doses of radiation can impart a very, very low risk of forming a cancer from the radiation way in the future, 15 to 20 years down the line. And we have examples in the literature, for example, of women that were a bit younger than Julie, so maybe in their teen years, getting radiation to their chest. And then we learn that 20 years later, when they become 30s and 40 years old, they have an elevated risk of breast cancer compared to patients who never got radiation. And so Julie has remaining breast tissue on the other side that wasn't taken off in a mastectomy. And so we want to think about how much radiation dose is going to go to that other breast when we're trying to treat the chest wall next to it on the other side. And that's not like I was worried about causing side effects or harm to that breast. What I was more worried about is how those very low doses that Julie wouldn't feel in the treatment, are those going to have a risk of causing a breast cancer later down the line, and how will protons versus X-rays or IMRT kind of affect that? And then when I talk to patients, just to drive the point home again, remember with each of these structures and the risks that we're talking about, we sort of break them into two groups when we discuss them with patients. And it has to do with whether we see these effects during the treatment or the effects later down the line. And the ones that we worry the most about here are the heart being a late effect. So this is like, I would tell Julie, you probably remember me telling you that it's not going to hurt your heart in the short term. It's not something you're going to feel, but are we going to harm the heart in the long term, 20, 30 years down the line, given that you're so young? And then how are the other therapies interacting with that as well? Just to show this, and I'll wrap up my little lecture before we can go through the plan. This is how we think about toxicity in radiation world. This is for cardiotoxicity or toxicity of the heart. And there's a couple of important studies to kind of know about. So the first thing is that this is how we kind of look at the responses for normal tissue or side effects, and then killing the tumor or curing the cancer. And the way we think about this is showing you radiation dose along the bottom. So it's increasing as you go along the x-axis. And then here, the chance of having a toxicity or curing the cancer increases as we go along the y-axis. And the idea here is that for a given radiation dose in the middle, so say 50 gray, for example, in the middle of our range of radiation doses we could give, the hope is that we have a very high chance of curing the tumor, almost 100%, but we have a very low chance of harming the tissue. And and it's way down here. And so part of the issue that radiation oncologists deal with is the shape of the curve of chance of causing a side effect or harming the tissue. We think most things work like this, where you can give a fair bit of radiation dose that's low and it causes no harm or no toxicity. As you give intermediate or moderate doses, you start to get a little bit of chance of toxicity, and normally we're okay. Most therapies like chemotherapies or surgery will also offer a very high chance of curing with a low chance of toxicity. We're okay with that. But as you get into these higher and higher doses, your chance of harming the tissue starts to go up very quickly. And it's this S shape that makes it sort of challenging, because we live in this area where these little green lines are. And you can see if we give just a little bit more dose, it starts to give a very high chance of toxicity very quickly. And I don't want to get too mathematical about this, but because it's shaped like this, that's when you hear your radiation doctor say, "Oh, I'm going to give you just a very low dose to your tissue, so it's not going to do anything." That's what we mean. It just means that we don't really think, based on our studies, that it's going to offer any significant chance of having a side effect that you feel or notice. The problem is that we don't always know that's how it works at the very low doses, especially for these side effects that happen way down the line and may have other things. As an easy example, it was always hypothesized or thought that if we give more and more radiation dose to the heart, you can have more and more major cardiac problems down the line. And again, we're talking 15 or 20 years after treatment, 10, 15, something like that, years after treatment. And the idea was that if you minimize dose to the heart, that you have less chance of toxicity. We don't know what that means at the bottom end of it. And then remember that most patients will have other things that cause problem to the heart. So for example, if they're smokers, that can happen. If they have cholesterol problems, we know patients that never have cancer that have heart problems because of cholesterol. The other case here, for example, in Julie's case, you received a chemo drug called adriamycin, which medical oncologists have lots of studies about how that can affect the heart. So we have these confounding factors, and the problem that can happen is you end up with, if you try to do models, you end up getting confused based on the radiation portion versus the confounding factors. And just to set the stage for how radiation doctors think about this study here in the New England Journal of Medicine in 2013 by this Dr. Darby, they looked at basically radiation doses to the hearts of women that received radiation for breast cancer, not sarcoma. And this was before we had very detailed planning and very good CT-based 3D planning to quantify doses to the heart. And so if you look at this curve, the shape is very different. And you can see that even at very low doses to the heart in this study, there's still risks of toxicities that they saw. So radiation doctors have now been kind of preconditioned to work as hard as they can to minimize dose to the heart, even to get it as close to zero as possible. Just to drive home the point, this prior model, the one I showed on the left, kind of argued if you give 1 gray, very, very low doses, that there's no toxicity. This said, oh, even at 1 gray, there probably is still some toxicity. Now, a lot of radiation doctors feel this one on the right is overstated. We don't believe that as much. And actually, there's been a more recent study that's looking in a much more detailed way. I wanted to put this up for viewers so they could look at this if they wanted to. It no longer is adequate to look at just the average dose to the heart like that other study did. And in fact, when this more detailed study did it, they found there was no toxicity at the very low levels when you're just looking at the average. But they found a much better measure is going to be looking at what we call substructures, which are like the arteries. Have you guys ever heard the term widowmaker that for the left anterior descending? So that artery, yeah, so that artery is right near the chest wall. And so that's one that we need to be paying attention to. We need to be looking more at the valves, the dose to the valves and the dose to the muscle. For example, we know that adriamycin has effects on the heart, but it's mainly to the heart muscle. And so maybe for patients like Julie in the future, we need to pay closer attention to the muscle and less to other things, and maybe not just look at the average dose. And so my point here is that there's kind of two things. One is that we have an evolving understanding of heart dose and how it relates to toxicity. And papers like this one from 2023 are going to be probably much more accurate in helping us understand what's really going on. And then the second part of it is that we really, as radiation doctors, especially when we're treating the chest wall on the left side where the heart is right behind it, we are sort of preconditioned based on our prior literature to work hard to make the heart dose as low as possible. We think it's very safe for the heart on average to get a few gray, maybe 2 to 4 gray when you're treating the chest wall. And then we're learning now to greater appreciate how these doses and where they fall in the heart probably matters. But like for your case, for example, we didn't have this information and we don't quantify those values at that point for your case.
So real quickly back on that. Are you also then working with specialists to ensure that patients are followed over the long term and that those substructures are being monitored appropriately?
Yeah, because I want to actually, that's a great point. So let me just show this graph again, the one on the right. Now, we talked about why we don't love this graph, but what these actual sticks mean coming out of the dots, those are actually what we call error bars. And what that's showing you is that for this dose at 4 gray, the risk is not 30% or whatever it shows here. It's actually anywhere from 10 to almost 50, because this is actually really complicated. Any complex system is going to have really variable outcomes on a patient by patient basis, not related directly to the amount of gray that they get to the heart. It's that plus, do they get other chemos? Plus, are they older? Are they a cigarette smoker? Are they exercisers? How's their cholesterol? And so to your point, we do follow even better. And something we're trying to do even more of is enhance that. There's a new field that's kind of emerging called cardio-oncology. Have either of you heard of this or had a visit? So cardio-oncologists are cardiologists that are specialists in dealing with heart effects of therapies or cancers or both that can affect patients. And so I know of at least one institution that has a department where we could send our patients to see those people, and it would be either people that already had some heart problems and then now needed therapy and had additional risk from the therapy, or a great example would be someone like you who has no heart problems, but we think that the therapies they got do introduce some risk of heart problems to their lifetime. And so because of that, we now want to try to optimize their lifestyle and their health as best as we can. And so for someone like you, I'm sure we talked about this. I probably made a joke that you shouldn't pick up smoking. That would be a bad thing to do if you're a patient who has risk to your heart from these therapies, or if someone smokes, we usually help them quit. Other things are encouraging exercise or heart healthy kind of cardiovascular exercise. We think that probably helps. And then, trying to be as heart healthy as possible. So if you're a patient who had radiation to your chest wall and your heart got some radiation, I would argue that they should work closely with their oncologist or primary care doctor to manage their cholesterol, just like everyone else does as they age, to try to minimize heart issues from that.
Do you ever make recommendations for patients to be followed by a cardiologist to try to stay ahead of things with because I know for me, for example, before I started treatment, not radiation, but I had a like base echo done so that we could have a good idea for what my baseline was. And then I had another one when I was on treatment, another one before surgery, and I'm not really followed anymore. But I'm curious if that happens for patients that have treatments near that area.
It probably should more than it does, right? I think that,
So-
yeah.
I mean, it does for me, like but I think it was driven more by the chemo that I was on than it was driven by the radiation. So I had to
Yeah.
have a base echo before I started chemo, and then I get an echo every 6 months, I believe, or every year. I'm gray on like exactly the timing, but yeah, I still do that, and we'll have to do that ongoing.
Yeah.
It seems like that should be like maybe that, I mean, that seems to be something that has been adopted with medical oncology. I wonder if this is if that's something that like should or would be adopted with radiation as well.
Yeah, so there are kind of two things. Well, there's actually three things. So one is that just as a high level comment, I think the three of us agree that we all wish medicine was a little less reactive and a little more proactive, right? And so we don't really do what you said, where like all patients that have any risk to their heart introduced through therapy. So either like a great example is adriamycin from a medical oncologist, or chemotherapy, or in this case, radiation near the heart. We should, like, in theory, all of those patients should have like good heart care going forward. That's something that we don't do as well in medicine today. I think that that's an area that we can improve, just being more proactive there. Now, the second thing is that what's unique about adriamycin is we know the side effect it causes exactly, and that is weakening of the heart muscle. Now, I'm not an expert there. I'm sure there are other effects of it, but that's something that we can follow. We understand how it happens. We understand the doses it's related to, and then we can follow it very precisely with something like an echocardiogram, because that's a direct measure of how strong that muscle is. Now, when I was showing this other study, one big takeaway from this more modern study of heart side effects from radiation are that you can't do what that New England Journal study did and just put them all together as major coronary events. That just means like a major, that would have either been a heart attack, a valve problem, a procedure related to a heart attack. This has been much more specific, where this study looks at different heart issues specifically. So heart failure, which is the medical term for weakening of the muscle, arrhythmias, which is damage or weakening of the rhythm keeping structures of the heart that make it beat out of time or beat incorrectly. They also looked at, you can have things like a valve failure. So this is like if the valves in the heart start allowing fluid to flow backwards or things like that. Those are all different types of injuries that cause different symptoms and different side effects. And so we're starting to look at that a little bit more clearly. And what this paper clearly showed is that the way the dose falls in the heart clearly impacts risk of these things differently. So you can imagine if the rhythm keeping structures or those nodes in the heart get a lot of dose, that might mean someone has a high risk of an arrhythmia, but they may not really have a risk of weakening of the muscle because the muscle didn't get much dose at all. And so we're just not quite at the level there. And I would argue that our problem is a little bit more complex. And so we have to model it better to be able to watch it better. And so all I would do, the best thing that I can do these days is, when available, I think that especially in patients like Julie, where you had both the chemotherapy and radiation near the heart, is to try to connect those patients with either a cardiologist, a primary care doctor, or a cardio-oncologist, if that's available, to try to monitor these things and optimize heart health going forward. The only other thing we can do is try to do the best we can with radiation. And I don't want to, again, radiation oncologists, I'm a little biased, but ourselves and our physicist colleagues have done a fantastic job of making this a way better situation than it used to be back in the 70s and 80s when that Darby study was originally calculated, because the amount of dose that's going to the heart is way lower these days than it used to be. So that's something where it has been a big win. And I think connecting people, following them, managing heart healthy lifestyles are really important. But the best thing we can do is minimize the dose that we give in the first place. And so this is how I sort of thought about it with Julie's case. And just to directly answer this question we got many times about how do we pick? Do we pick protons or x-rays? And I happened to have both of them available at the time that I saw Julie in clinic, and we could pick between them. And so how do we pick? For me, the top consideration for this case was the heart dose, because I knew that I could cover the target or give the dose I needed to safely with both X-rays and protons. And again, I think they're both effective. And so the question is like, how are they different? For me, in this case, with a left-sided chest wall, in knowing that I had to give a high dose for sarcoma in the adjuvant setting, knowing that Julie was young and healthy, I was pretty worried about the heart dose, because this is where we think that even a few gray could matter in the long run. We don't know for sure, but remember, radiation oncologists are biased to give as little dose as possible. And if we can get zero, that's better. That's the best thing. And so I knew up front that proton therapy would reduce the mean dose, the average dose to the heart, which was the best metric we had at the time. And in the typical setting, we'd be happy in the chest wall setting. We know this from the breast cancer world, that if we can keep the mean dose to the heart to 4 gray or less, we're very happy with that. And the study I just showed you from the Journal of Clinical Oncology in 2023 would argue that there's not added side effects with that kind of a metric. In her case, the mean dose was only 2.6 gray, so very, very low, and that was a big advantage of proton therapy for this one. And then the other thing is that we don't know the dose at which the valves or the coronary arteries or the things start to get sick from the radiation or have these side effects many years down the road. But if you compare X-ray or photon therapy to protons in her case, the difference is honestly some dose, so a very low level that's unlikely to cause problems, but still could. Whereas protons gave the valves in this case 0 gray. So it got no dose at all, which is, again, we don't know how to model these things at very low doses, but 0 is always better than some. The other thing that we have to think about in younger patients, and this is why often radiation doctors are enthusiastic about sending their patients for proton therapy if they're very young, is that we think that these lower doses of radiation that can be spilled into healthy tissues during IMRT or X-ray therapy, those can potentially cause second cancers. And that breast tissue on the other side is the tissue that we would worry about that the most in this setting. One of the biggest downsides of IMRT for something like Julie's case is that it would have given some low doses to the other breast, whereas proton therapy gives 0. And so, we don't know how to model low doses of radiation well. I've said that a bunch of times, try to drive that point home, but I think everyone would agree that if it gets 0 gray, then it's unlikely to have a risk of second cancer in the long run. There's really not a lot of drawbacks in this case. We thought about how the skin dose could be a bit higher. I believe Julie, you and I talked about that, but the skin heals, and I knew Julie was an active patient that would be doing physical therapy, and so that would promote healing and offer the best kind of soft tissue healing there. So I felt like that was a minor drawback. And then, a lot of times we do have to think about operational concerns, but those are the absolute last priority. We always do what's best for the patient first. Proton therapy does require more work. So I think, Julie, we had a big battle with your insurance company to get it approved. Patients in their 30s, early 40s are patients that radiation doctors would feel would benefit from the second cancer risk reduction of proton therapy. But in that age group, it's very challenging to model that compared to like teenagers, for example. So that's why some insurances are not kind of approving for patients in their late 30s or mid 30s, things like that. But those were the considerations I had for why to pick. And then we ultimately did go with proton therapy.
So just a quick question on the insurance approval. I remember we waited quite a while, like a number of weeks, because of all the insurance back and forths that were going on. Like, is there a point at which you say waiting for the approval is more detrimental to the side effects from the other therapy, so we're just going to go with the other therapy? Like, how often does that happen? Because I know insurance approvals are a major bottleneck and challenge for patients and physicians. So how often is care being changed simply because the approval process that's in place?
That's a really great question. And I think what's tough is we probably have to recommend that patients talk about this in detail with their doctors, because it does matter based on the setting. So for your setting, what we were talking about is giving radiation after surgery, right? So tumors out, If we're waiting, there's no chance that the tumor is going to grow and cause problems while we're waiting because it's out. And so that's something that I see you're smiling because you have that little hitch in your case, but you can imagine that if it was still in and we were treating with radiation without surgery, if it's growing and growing and growing, it could cause problems and make people sick. So that's an important thing to think about. You have more time when you're after a surgery. And then I always tell patients that we should look at studies. So sarcoma studies generally try to have their radiation delivered after surgery within about 6 to 8 weeks. And that basically is balancing healing. You don't want to start too early because if it's not healed, giving radiation can mess up the healing and then you can have wound issues. If you start too late, then there's kind of two things that could happen. One is that if it's going to come back, it could have already started to come back. And if you have more cancer cells there because it started to come back, you're less likely to cure it. So if you wait longer, you're less likely to cure it. Or if it's not going to come back and you wait 3 months, 6 months, 9 months, and it still hasn't come back, the idea is that it may never, and then they may not need therapy. And so generally I tell patients that we try to get it within about 6 to 8 weeks or so. But I've had patients where we might have waited 10 weeks or 12 weeks for wound healing problems, and then we still can treat, and that's okay. Past 12 weeks is when I start to get worried and we start having a conversation about that. Now, in your case, you have to add in the extra layer of doing this differential, like pros and cons, right? Because if we're waiting and waiting, then we start to wonder, okay, it's not like X-rays or IMRT are going to give a huge dose to the heart. We're talking about maybe 2.6 gray in your case versus maybe 5 gray or 4 gray, right? And if you ask me to put a number on it, how does that change your risk of heart problems 20 years from now? I cannot do that. Like I can't put a number on it. I do not know. It may be completely irrelevant. We don't know. And then you have to start to weigh that against like, well, what if I wait another week, right? That kind of a thing. So it becomes pretty nuanced and very personalized as we go forward. And I can tell you that if we got to that, I think I looked and it was 8 weeks from your or maybe 7 weeks from your surgery to when we started. If we were in that 12-week area, I probably would have suggested that we go with IMRT. Because remember, curing the cancer is the first priority. I think every patient would agree that if the treatment is not achieving your goals, which in this case is to cure the cancer, then we sort of lost before we've even started, right? So I think that's what I would have thought of in this case. Should we review the plan?
Yeah.
Okay. Let's go ahead and do this. Trying to work 2 computers here, so sorry. Okay. This is your radiation plan. And I thought what we could do is kind of show it for informational purposes, and then we could also talk about how radiation doctors look at their plans and how they're made and what we look for. So this is your body here. The way that we look at this is you're sort of laying in the screen with your head going in the screen and your feet coming out, and you're on your back. And the only reason I tell people that is because the left side of your body is actually on the right side of the screen in radiographic images. Is often how we look at it. And right here, we're in the middle of your chest. Here's your heart in the center. Here's your breastbone, like kind of like right here that you could feel. Your 2 shoulder blades are in the back here. Here are your ribs and your backbone. The 2 lungs on either side in this view are mostly black because they're mostly filled with air, same color as the air on the outside. And then on the on the right side of your body, you have some residual breast tissue here. That's what these little gray lines are. It's just the breast tissue. And then on the left side, you can see that that's gone because that's where they did the surgery. And this muscle in this little space here is where we wanted to treat. And so we can scroll up and down your body. And this scan is that planning scan or that CT simulation that your doctors may tell you about. This is the one that we use to plan the radiation. And how do we do that exactly? So what we do is we tell the computer everything that's normal. So in this case, we outline your lungs and your heart. We have the left lung in green, the heart in red, and the right lung in blue. And then we also outline things like the esophagus that's in there, and then our target. And I kind of showed before, your tumor target is made the way that, it's based on standard of care. And after talking to your doctor, this is a classic field that treats the chest wall. That chest wall space is where we thought there was risk that the tumor could come back. It's pretty standard for sarcomas in this area. And so it goes up and down the chest wall like this. And you can see how in a left-sided patient, the heart is kind of on the left side of the chest. You can see how the heart is right next to, and you're in thin, fit patients, there's not very much space between the heart and the chest wall. And then the lung is right there as well. But you can see things like the esophagus right here is relatively far away in radiation terms. The right lung is relatively far away. And then I wasn't able to bring it in because to do proton therapy, you use a separate software, but we also do outline the right breast to calculate dose to that area. Then we run a big equation and we tell the computer, put in that 60 gray to this target here, but don't give too much dose to the heart or the lung. And we do that quantitatively by saying, don't give more than such and such dose. And remember, I said for a chest wall with the heart, we're looking for a mean dose of less than 4 gray. So that's kind of something that we look for as a goal. And once that's done, what it does is it gives us the dose, and I can kind of show you what that looks like here. And this is the part where I think, Katie, you said before you thought it looked like one of those storm maps, or I'll sometimes use the analogy of a topographic map, but I can scroll up and down each of these slices, and this shows the dose distribution. And there's a couple of things that I want to show here. Let me change this first. Sorry, my mouse is being a little slow and not cooperating, but a couple of things I want to do is I'm going to turn off some of these lines. These are the dose lines that show the different levels. The first thing that I look for is the radiation dose something that is exactly covering the target and nothing more? So again, that blue target right there, I want my dose lines to look exactly like that, and it does pretty much for the most part. This is showing me the levels. The reason this is in 5,000 is this isn't just in centigrade gray. This is 50 gray instead of 5,000 centigrade. It's the same thing. And as I scroll up and down, you can see a couple things. The first is that radiation doctors will often try to give 100% of that dose to that target, but it can be challenging due to the way the physics of the radiation works. And so we typically instead look to make sure that something like 95 or 97% of what we prescribed, in this case, like 47.5 gray, covers that target. And so I can see that here if I scroll up and down. It does a really good job of covering just the target and nothing else. One catch of proton therapy is, remember, those particles are kind of heavy and you have to control them. It can be hard to control them in something that's mostly air like lung. And so you can see how there's a little bit of dose spilling into the lung with proton therapy just because there's some weight to those particles. Then the other thing that you look at is lower doses, and this is where proton therapy really shines. So let's go down to something like 10 gray. This is something where we think it could cause some side effects in the long term, but maybe not you'd feel in the short term. And you can see how small this really is. Really just a small part of the chest wall outside of the target, a little bit of the heart, a little bit of the chest of the shoulder outside the target gets some dose, and a little bit of the lung. But the nice thing about proton therapy is it keeps those lower doses really, really tight. If we now change this to 1 gray, so remember, 1 gray is the area where we don't think you'd ever perceive it. It probably won't cause any side effects even in the long term, but we don't know. Maybe the 1 gray contributes to having a second cancer of the breast or something 20 years down the line. If we did the 1 gray on an X-ray or IMRT plan, it would kind of be like almost your entire body, because remember, it uses lots of little beams from all different directions, and that's where those low doses come in. Here's the 1 gray line for proton therapy. You can see it's this dark blue line that really is only giving a bit more radiation to some tissue outside the target. But like your right breast, for example, gets basically 0 gray or no radiation. That's where we really would see a big difference. And I'm sorry I don't have a comparison to show you. I don't work in the system anymore, so it was hard to kind of set this up with a comparison. But this is where proton therapy really shines. And so it did exactly what we wanted it to do in this case, where it gave a very high dose, and then it minimized dose to the heart and dose to the lung and dose outside the target. The last thing I'll show you is I set up, this is called a dose volume histogram. So we don't only look at that topographic map of the dose and where it is, but we also look at some statistics about the structures we talked about. And we look at it in graphs like this, where on the y-axis it's showing you the percent of that thing that we're talking about that's covered by the dose, and then the dose here at the bottom. And so what you're looking for is this blue, remember, is our target. We want most of the target to be covered by most of the dose. That's what we're looking for. And if we use our crosshair, we can kind of put it on. And if we look at that 95% level, kind of where we want to be covered, we have like almost 100% of the dose going to 95% of our target. That's something that we often look for, and we'll see that. So we're very happy with that. We're for things that are normal, not the target, not the cancer, we want as little dose as possible to as little of the structure. So here's our heart. The heart did get some very, very low doses. This is in that 1 gray or that 50 centigrade, 100 centigrade, 1 gray range. But really remember that at the time we did this plan, the biggest metric that radiation doctors were using is the mean dose. So that takes the whole heart and calculates the average dose to the whole thing. Remember, we wanted this to be less than 400, and in this table, it's showing us that it's more like in the level of 260. So that we're really happy with that. So this is, in my opinion, a place where proton therapy really shines. There's a lot of uncertainty about whether X-rays are better or protons are better, but what doctors do is they take the pros and cons, and we build in all this uncertainty, and we try to make the best decision we can. And when I talked to Julie, your insurance company, they agreed that this made sense in someone who was in their 30s and has this cancer, and we're treating for cure. And so that's why we went forward with it.
Neat.
It was such a good laugh. There's nothing left to say.
I thought it was great. I mean, these are things that, I don't know that we always have the luxury as patients to hear someone walk through the thinking, because I think for you guys also the thinking is, this is what you do every day.
Yeah.
And so it's almost not that it's taken for granted, but it's, as patients, we don't always get the luxury of being able to like hear step by step how our physicians are thinking about the decisions they're making and why they're making those decisions. So I thought this was really cool, and I feel really lucky that it was my own case that we got to look at.
No, I appreciate you kind of giving us the opportunity to do that, because it really is, I think one thing that is important to drive home is that with the difference between proton and X-ray therapy, like we will never have a randomized trial in sarcoma to ask that question for your case. Like there's just very few chest wall sarcomas each year, and there's not enough to like run, there's better studies to run with those patients. And so I think we won't ever have it. And so the best thing to do is to just ask your doctors, I think, what they think the pros and cons are, and then to explain why they would choose one thing over another. One quick point is that most radiation doctors, they have the machine that they have, right? It's not like each one can go out and buy their own machine. These machines are very expensive to run. They require whole teams. They belong to centers, not doctors. And so what I would tell patients is that most of the time, what you're treated with doesn't really, we view them all kind of similarly. So the better question is, like, if you're going to have something that's maybe a little less common or less standard, to understand what the advantages of, for example, proton therapy is over X-ray. There's different proton machines, there's different X-ray machines. Those machine types probably matter a little less. Hopefully that makes sense. It's really, the reason we spent so much time is that it's kind of like a different tool entirely versus just a different flavor of the same tool. Yeah.
I have to say though, like I do think I think understanding the differences in the types of treatment is important and a good thing for patients to know like what the options are. But in general, Julie, I can share your sentiment about like seeing your own case discussed through, because I had that same experience when I made a YouTube video with my oncologist about my case. And there was things that I learned about my case that I didn't know. And it was a very, it's a very interesting experience to go through that, because as a patient, you're so blind when you're going through the entire experience that like all you know is like, I show up in the office one day and this is what has been decided on. And for me, I know like I really appreciated like hearing the like, okay, I considered A, B, C, and D, and this is why I chose C. Not just, I chose C because of the study, like hearing the context of like, I evaluated you because of your age and like the whole picture versus I evaluated because of X study. It's like I evaluated you in the context of X study was the difference in hearing something about my own case.
Yeah, I mean, I think that's always been something that, having a physician present the scenarios that were discussed or the options that were discussed, and then present the rationale on why a specific option was chosen, I think is really important. And I don't know that it's always presented in that way.
Yeah.
One thing I find really hard to do to try to achieve that goal, because I agree with you. I think every patient should have their case kind of discussed with them in this way. But I think one thing that I always think about is I feel like when I engage the medical system as a doctor with my own patients versus when I engage the medical system with myself or my family, I feel like it's different for me, because it's very easy for me to think about heart dose and risks when it's not my heart, right? So I don't know if that makes a difference. Like I think that it's just, it's like we can argue online or have, very vigorous debate about proton versus x-ray therapy for chest wall, because the reality is if you take two patients and one has a mean heart dose of 3 gray and one has a mean heart dose of 6 gray, we can't put a number on. We don't really know what that difference is going to be. And it probably varies from patient to patient. The difference in like the outcome or the toxicity, right? But then when you flip the conversation around and you're the patient, it's very easy for me to brush off that unknown because it's like something we just don't know that happens to a group of my patients. If it's an unknown that's about you, it's a very different thing. I don't know if you feel like that makes a difference, but that's one of the things that I find really hard to do this well with patients, because one person might view me saying, well, we don't really know the difference between 3 and 6 gray. It's probably not a big deal. But another patient might want to know exactly the number difference in their risk, absolute number, right? And we don't have good answers for that always.
I mean, I am that patient that asks for that exact number, but I also have been that patient who there has not been a single sure answer about me ever, right? Like, because I'm the super rare case. And so I'll say for me as a patient, like that is the conversation I want to have with a physician. Like, even if you don't know, like I want to know your thought process of like, yeah, I tried to look it up. Those answers don't exist. So I'm giving you, this is why I think this is the best recommendation. I think that's the piece that's missing, is because when those are difficult conversations to have because you might not have the right answer. And so you don't know how they're going to respond. When it gets redacted from the conversation entirely, the patient doesn't have the opportunity to know the thought process that went behind their treatment.
Yeah. No, I mean, the goal should be to have it for everyone.
Yeah. And I will clarify that in my case, we did talk a lot about when it came to radiation, we did talk a lot about the options and, why one was superior over another, perhaps even, even if it's limited superiority, right?
How was it for you, Julie, to hear some of the same things back like afterwards? Do you feel like you absorbed a lot more now that you've been able to be distant?
Oh, sure. Yes. Yes. I don't think, yes. I'm not sure what I actually absorbed at the time. I don't know if I absorbed all that much. And in fact, my husband would always come with me to the early appointment, like to the appointments right after I was diagnosed. And I felt like he absorbed everything and I absorbed very little. So, in the early days, I think there was just so much like shock, and like there were other things in my life that I was having to figure out. I don't even know how much of it I really understood.
Yeah, I say that too, because I say like when I like went through my case with my oncologist for that video, like I learned a lot more, but I also had a different level of knowledge learning that. And so part of my curiosity is like, I don't know, if I was told all of that stuff early on, would it have the same impact that it had for me? Like when I listened back, that's like a hard thing to know too.
Yeah. I mean, I don't think there was anything that we went through today that I didn't know. but I'm thinking a lot more critically about it now because I have the space to, versus then it was just, okay, this all sounds good. Let's move. Let's go.
Yeah.
Such a
It's kind of,
complicated topic.
and especially if you're like in a setting too where it's a little bit more urgent. Like there are patients that don't, like we said before, they don't have a surgery, and so we might have a consult and then we're talking about starting radiation like 5 days later, 7 days later. It's not very long to kind of think about these aspects in general. Yeah. So I think, and I think it'll be something we try to do better as we go forward. It's something that I've definitely had an evolution of how I think about it. I think I mentioned before that just because a lot of our conversations, one of my jobs at work is to manage quality for the cancer program. And so we do lots of like standardization, and like everyone should be doing things the same way and everyone gets the same thing. And so at a high level, you try to make a decision about whether every patient with chest wall sarcoma in their 30s should get protons or not, that kind of a thing. But then, it's like, I think more and more as I mature as a physician, I'm thinking more and more about the importance of genuinely personalizing therapy for everybody, and like those pros and cons that I had listed on that slide could be different for a different patient, even if they're the same age with the same cancer.
I mean, not only personalizing therapies, but also personalizing the conversation around the therapies, because person A, different people have different thresholds for what they can absorb and even what they want to know.
Yeah, there's a lot to do. I'll be working at this for a while. So
I'll point out that I just got teary-eyed when you said that, Matt, about like the more you've matured as a physician, the more you think about an individual patient. And I don't know, I just wanted to point that out because it was an unexpected emotional reaction. But I think it like goes to show that like as a patient, like sometimes you can feel lost in a like, oh, you're just this bucket of people that we're comparing things against. And so like hearing that from a physician is like very impactful. So who knows, maybe a patient you say that to in the future may be positively impacted by that.
Oh, it's great to hear. I hope. Yeah. Always practicing to do better. Yeah. All right. Well, so should we close it out, and then I'll post this up.
Sounds good.
All right. See you guys later.
Thanks. Bye.